Okay, hello everyone, and welcome to the second part of our lecture on dental caries. So today's lecture we will look at primarily two learning outcomes. Number one is explain the Stephens curve, and number two is explain the histopathology of enamel and dentinal caries. Okay, so the first question is, what is Stephens curve? So the Stephens curve is a graph that shows what happens after the consumption of sugar in relation to dental caries. Okay, so as you see this graph over here, you would realize that this is a graph that is plotted against the pH, the plaque pH versus the minutes or the time after sugar intake has been taken. So if you notice, as soon as there is a sugar intake that is taken, there is a sharp decrease in the pH of plaque, and as the pH of plaque decreases, it becomes an acidogenic environment, thus increasing the susceptibility of the root surface to dental caries. The period this the period of the pH to become basic again takes approximately 20 minutes, and that's because of the buffering capacity. So this is actually what is described as the Stephens curve. So let's look further and see what the
number one
implication
is
of
after
the sugar intake, demineralization of tooth surface takes place due to the drop in pH as the bacteria in the tooth convert the sugars to organic acids, which is what we have actually understood in the part 1 of the dental caries lecture. So basically what we have actually understood in concept is dental caries is a multifactorial this infection wherein you need the tooth substrate, you need dietary carbohydrates, you need the microorganisms, and all of them need to interact in sufficient amount of time to be able to produce organic acids, which cause demineralization of the inorganic component and destruction of the organic component, leading to this cavitation. Now, this is all because of the fermentation of sugars by the microorganisms that are present, primarily Streptococcus mutans species, giving rise to organic acids such as lactic acids, which drop the pH of plaque rapidly. So after 20 to 30 minutes, the saliva buffers the pH and it returns back to normal levels. Now this is more rapid if there is a presence of fluoride, which is one of the reasons why we are advised to actually have fluoride in our toothpaste, okay, thus increasing its adsorption on the enamel surface and providing crystals called fluorapatite crystals, which are more resistant to acidogenic destruction. Okay, so basically the implication of the Stephens curve is that spacing period of sugar intake hours apart allows the pH to return to normal. However, increased frequency of sugar intake means demineralization occurs more often, and the time period between drops in pH are not too long enough to allow effective remineralization to happen. Okay, so our advice to patients in terms of reducing the frequency of intake of highly sugary foods is because of the evidence of this particular Stephens curve. Okay, so the curve that actually clearly explains and has shown that there is a sharp fall in the pH of plaque with every consumption of sugar. All right, and the buffering capacity of saliva to return back to a normal pH of, or rather a basic pH, takes about 20 to 30 minutes. So if you increase the frequency of carbohydrate intake, you increase the chances of you continue to increase the uh, lower pH in the oral cavity for longer duration, that thus increasing demineralization and increasing the chances of developing caries. Okay, so this is the first aspect. Right, so let's move on to the second aspect of the lecture, which is pathology of dental caries. Right, so we've understood the etiology of dental caries, we've understood the concept behind how a caries lesion initiates, what is the chemical process that is taking place. Now let's look at the microscopic process that is actually taking place. Now this actually is a very beautiful picture of different stages of dental caries. So if you look at picture number 1, here is there is no change in surface. Picture number 2 here shows a white spot lesion. Picture number 3 shows destruction of surface enamel. Picture number 4 here actually shows us destruction of enamel and brownish decay. Picture number 5 actually here shows you a restoration that has taken place and secondary caries under the restoration, as well as advancing caries involving the enamel and dentine, and eventually basically destruction of the crown structure. So this is actually the natural progression of dental caries uh, there is um, uh, if there is no change, or rather there is lack of intervention that has taken place to stop the process from progressing. Okay, now this is in this lecture I will be showing you ground sections, extracted teeth, ground sections, as well as some radiographs of the same teeth in order to show you the correlation between how a caries lesion looks clinically and how does it look microscopically. Now that you are already a clinical student, many of you are already seeing patients, and as you observe patients in clinic, the most important learning outcome for you as a course learning outcome in oral pathology and oral medicine is to be able to correlate clinico-pathological processes of disease. That means what you are seeing clinically, how does it actually appear microscopically, what is the disease process, and so on and so forth. So now this is the distal view of posterior tooth, and what you're seeing here at the proximal surface is brownish discoloration, right, and surface loss of enamel. Now this correlates to this radiograph where you're actually seeing the slight loss of opacity of the in the enamel, as well as a slight loss of opacity in the dentine, okay, indicating that this is a caries. Now when the same tooth is actually undergoes ground section, all right, and you actually notice, then we will be able to appreciate that there is a lot more destruction that has taken place under the enamel, and the lesion has actually even shown changes in the dentine. So a radiograph of this ground section, a section of the tooth, clearly shows this radio opacity that is progressing, rather is a large radio opacity in the enamel, and a small radio opaque lesion that we are actually a radiolucent lesion, sorry, that we are actually seeing in the dentine. So this is how changes are taking place in the enamel and dentine as the caries lesion progresses. So I will explain further as we look in detail in the aspects of the pathology of dental caries. Okay, so let's look at caries of enamel first. So we could have smooth surface caries or we could have pit and fissure caries. So let's look at first smooth surface caries. So the earliest visible changes is the loss of transparency resulting in an opaque chalky lesion, which is also called as the white spot lesion, which you guys are all familiar with. So what exactly is taking place in a white spot lesion is accentuation of the pericymata. Okay. Now, slowly progressive / arrested brown or yellowish pigmentation of enamel takes place thereafter, after the white spot lesion progresses further. In a longitudinal section, it is cone-shaped with the apex directed towards the dentine. Now, this is the most important thing that we need to understand in concept. So, I'd like to rather draw this thing. So, if we are actually looking at a tooth surface like this, all right, let's look at this to be the tooth surface, all right, and let's say this is the the dentinal surface, and this is the pulp. So when we talk of smooth surface lesion, what we're saying is that you develop a white spot lesion, right? So which is clinically resembles a whitish chalkish lesion. The lesion in enamel actually progresses rather like this, right? So the apex of the carious lesion is directed towards the dentine, whereas the base of the cone is present on the enamel surface, right? So this is how a smooth surface lesion looks like in this is exactly what we were just mentioning here, okay, all right. So if this is the enamel, this is the dentine, this is the pulp, this is the brown section of that tooth. So what you've actually just seen is that a large carious lesion is here, right? And the apex is towards the towards the DEJ, while the base of the cone is on the smooth surface. Okay, so as this progresses further, you actually see the changes in the dentine, which I will actually explain. Now that we're here, we've got to understand one important concept, that caries progresses faster in the hypomineralized areas of the tooth structure. And one of the most important hypomineralized structures is the DEJ, and that is the reason why once caries reaches the DEJ from the enamel, it quickly spreads laterally to produce a broader based cone or a broader based lesion at the DEJ, and a more conical, or rather the cone of the dentinal caries towards the pulp. So this this lesion or smooth surface lesion is described as the caries cone. So this is different. So you will be, as I explained, you will be able to understand the difference between the caries progression in smooth surface caries as well as compared to that in pit and fissure caries. Okay, so this is how smooth surface caries. Right. So as compared to pit and fissure caries, so what happens is lesions more often start at both sides of the fissure wall rather than at the base. Now, penetrating nearly perpendicular towards the DEJ, okay, there are visual changes as chalkiness or yellow, black, or brown discoloration, as we know, similar to the smooth surface caries. The lesion is angular, cone shaped, with base directed towards the dentine and apex towards the enamel. So, this is actually one of the most important aspects or rather the concept that we need to understand. So increasing severity of alteration is found with increasing narrowness and depth of the fissure. First thing that we look at, we need to understand, is how are pit and fissures formed. So these fissures are actually formed during the developmental process, when actually the enamel has formed. There are remnants of the ameloblast, right? So and what happens is, when and in these deep areas of the fissure, as they are forming here, what exactly remains inside these fissures before the tooth actually erupts into the oral cavity are remnants of ameloblast, capillaries, enamel organ remnants, blood, and empty spaces. Now, these contents of a fissure act as nutrients for the bacteria, in addition to the dietary sucrose that comes in, that food to be entrapped in these fissures. Now this slide here shows you the different types of anatomical fissures, bitten fissures, that are possible. So there is something called as a V-shaped fissure, you have inverted Y fissure, we have K-shaped fissures, we have I-shaped fissures, and all of them have contents inside the fissure, inside the pit of fissure. Now what happens is, those contents, in addition to the dietary substrate that gets entrapped over there, gives the bacteria a sufficient amount of nidus to commence the carious lesion inside a pit or a fissure. Here you see a ground section of a pit and fissure here. This is the enamel surface, this is the dentinal surface, right? And this is basically the pit that we're talking about. So unlike the smooth surface caries, where there is a broad base on the enamel surface, and the cone, the carious lesion is like a cone pointed towards the dentine. In a pit and fissure lesion, there is actually the lesion starts laterally on the walls of the pit, right? So this is again here contents of the pit, okay, decalcification that has taken place, and then there is caries that. Okay, pit and fissures usually produce greater cavitation than proximal smooth surface caries, right? Because of the anatomy of the pit, there is a lot of content that's available, and then it is more easier for the bacteria to escape mechanical cleaning, and that's the reason why they produce larger cavitation, tend to produce more undermining because of difference in shape of the cavity, In newly erupted teeth, brown stain is indicative of underlying decay. Okay, so teeth of older individuals, it may be due to arrested or uh, now, okay, let's look at this lesion here. What we're seeing here is this is the pit, and this is how the carious lesion has progressed in the enamel. And once it has reached the DEJ, it spreads laterally further, right? It's spreading laterally further, and then again the lesion is forming a conical lesion with the apex towards the pulp. So this is the difference in the progression of enamel caries in pit and fissure lesions as compared to smooth surface lesions. So as we said, in smooth surface lesions, you basically have the caries cone, which is apex towards the DEJ. From the DEJ again it spreads laterally, and then again another cone. So this is smooth surface caries, while this, the next one which I'm just drawing, is pit and fissure. Sorry about that. Right, there's lateral extension at the DEJ, right, and there is a caries lesion in the dentine. So the second one that I'm drawing is pit and fissure caries. Okay, so why is this difference that we see, right? The difference is because number one, the anatomy of the pit, all right, the caries progression in the enamel follows the anatomy of the enamel rods, right? Why is there lateral extension at the DEJ is because the DEJ is a hypomineralized structure, and thus the bacteria along with its byproducts is able to further destroy the hypomineralized structure laterally, causing demineralization destruction, and then the lesion in the dentine takes the same course both in pit and fissure and smooth surface caries following the direction of the dentinal tubules. Okay, now this is the ground section and the radiograph of a tooth that was actually restored with amalgam. So, but there is underlying secondary caries that you are seeing. So, if you notice here, this is the restoration. Under the restoration, there is an enamel lesion that is taking place. And then once it's reached the DEJ, it is spread laterally to actually undermine the enamel in this region near the cuspal region, and a large dentinal lesion that we are seeing. So if this tooth is left untreated, what's going to happen is, because the enamel is undermined, eventually there's going to be a large cavitation under this restored tooth. So this is what happens when caries progresses. Okay, so now let's discuss the microscopic changes of enamel. So the typical smooth surface lesions have been divided for descriptive purpose into number of different zones. Okay. Now the most important thing for you to remember is that when we're talking about the zones, we're actually talking about from the inner advancing front of the lesion, okay. What does that mean? So that means we're talking about if we're talking about smooth surface caries, okay, and this is the lesion in enamel, right? This is the, what we're talking about is translucent zone here, so starting from here, dark zone here, right, body of the lesion here, and this being the surface, layer. Okay, is this clear to everyone? So we're talking about translucent zone over here. All right, let me move back to the pointer. Right, so we're saying translucent zone is this is a dark zone, right? This is the body of the lesion, and this is usually the surface layer. So each of it has a lot more content that we need to understand in terms of why these zones actually appear, and it is only for an academic purpose to understand the various changes that take place microscopically, that these various zones have been labeled. It is not easy to identify them on light microscopy, but rather we need polarizing microscopy to be able to identify an image of polarizing microscope. So, third point is no sudden or dramatic change from zone to zone, but rather gradual series of changes. This layer, right? This is the advancing front. So we're talking about this being the first layer, the yellow being the second layer, this being the body of the lesion, and then the surface lesion. Okay, why is there difference in this appearance on polarizing microscopy? Is because of the amount of mineral content that has been lost based on the progression of caries. So number one, let's look at the translucent zone. What's exactly happening there? It appears to be the earliest change in enamel at the advancing front of the lesion. Okay, it's detected in about half of the lesions. It appears structureless. Okay, it is characterized by approximately 1.2% loss of mineral, mainly magnesium and carbonate. Okay, there is no loss of organic component yet. Okay, so this is the advancing front of the enamel. Second is the dark lesion, just superficial to the translucent zone. It appears dark brown when examined by transmitted light. Okay, a constant feature of caries lesions, varying width. It shows positive birefringence in polarized light. What do you mean by that? Basically, the previous slide where I had shown you the yellow color, that is indicative of positive birefringence, which is seen in under polarizing microscopy. Under the radiograph, it appears radio opaque. The total amount of mineral loss is 6%. The body of the lesion is the largest zone. Okay, demineralization phase has taken place. The striae of Retius are enhanced. Okay, in this phase, at the electron microscopic level, there are prism structures is well marked, showing a pattern of cross striation. Okay, microchemical analysis indicated a reduction of 24% in mineral per unit volume compared to sound enamel. Okay, this is the part of the lesion that on regular routine radiographs appears radiolucent. So what we need to understand is the radiolucent lesion that we actually see on IOPS when in a clinical case after you've taken a radiograph basically indicates to you the body of the lesion. Technically, when you excavate and go into these lesions, when you are excavating caries, you will find that the lesions are much larger. That's because of there are other zones of caries as well that are present. There is increase in unbound water and organic component content due to the ingress of bacteria and saliva. So this is the largest zone, the zone which is called the body of the lesion. The surface layer is usually 40, maximum 40 micrometers thick. There's only 10% mineral loss. It's thinner in active lesions and thicker in inactive lesions. It's thicker in inactive lesions because of the surface absorption of fluoride, making the surface resistant with the formation of fluoraptide crystals. It appears relatively unaffected in initial lesions. It retains a negative birefringence in polarized light. That means it appears black. Okay, in microradiographs, it is radio opaque, similar to normal tooth structure, and its characteristic finding is broadening of prism sheath under the electron microscope. Okay, right, now this is a diagrammatic representation to show you how a caries lesion actually progresses. A smooth surface caries lesion, let's say that this is the enamel caries that has progressed. You're seeing the broad base towards the surface. You're seeing the conical shape with the apex of the enamel caries cone towards the DEJ. Okay, the gap between the white area between the surface and the body of the lesion is the surface layer, right? So body of the lesion, so on and so forth. So the most important thing that you need to appreciate here is even before the enamel caries actually reaches the DEJ, because of the percolation of bacterial components and organic acids, there is already a change in the dentine that is taking place. Now, dentine is a very differs from the enamel in that it is a living tissue and can respond to caries attack. Right. So it also has relatively high organic content, approximately 20% by weight, which consists predominantly of collagen. Okay. So as the enamel caries progresses further, reaches the DEJ, look at the changes that are taking place in the dentine. So the first change that actually takes place in dentine is that the dentinal tubules that are there, which contain the odontoblastic process, these odontoblastic process perceive irritation because of the bacterial products and organic acids, and there is a retraction of the odontoblastic process from the DEJ, from the dentin in the dentinal tubules. This is basically gives rise to the dead tracks. This is the dead tracks that are basically forming. Okay, and slowly and steadily, if there is no intervention that is taking place, it's giving rise to cavitation, right, and further progression of dentinal caries, and also changes in the pulp, right? So as the bacterial components start affecting the pulp, start percolating from the dental tubules towards the pulp, there is a layer of reparative dentine that starts to form. Okay. So this is the same caries progression, diagrammatic representation in a pit and fissure caries. So apex towards the pit, broad base towards the DEJ, right? As the enamel caries progresses, changes in the dentine start off. This is the formation of dead tracks, right? Then once it has reached the DEJ, it spreads laterally to form a broad base caries structure at the DEJ, and a conical structure moving towards the pulp. So as it's coming closer towards the pulp, as dentinal caries progresses, right, we're seeing a reparative dentine formation in at the pulpal layer. Okay, so let's look at the caries of dentine. So lesion has spreads laterally along the DHA, often undermining the enamel. The reason why it spreads laterally along the DHA, I've already explained, is because DHA is a hyperventrilized structure. It proceeds along a saucer-shaped front and follows the direction of the dentinal tubules. The lesion is cone-shaped with the base at the DEJ apex, at the DEJ, and the apex towards the pulp, which I have explained. Affected dentine displays different degrees of discoloration from brown to dark brown or almost black. Okay. So microscopic changes of the dentine are broadly described as 5 zones. Okay. So these zones, number 1 is called the zone of dentinal sclerosis. Number 2 is the zone of demineralization. Number 3 is the zone of bacterial invasion, and number 4 is the zone of decomposed dentine. So this is again based on one being the advancing front, right? One being the advancing front of the caries lesion. So a fifth layer, which is actually seen in the pulp chamber deep to the dentinal caries, is called the reactionary dentine, which we have seen in the diagrammatic representation. So dentinal sclerosis takes place because as soon as the bacterial components, the degradation of the components of the enamel caries start percolating and reach the dentine, there is retraction of the odontoblastic process leading to formation of dead tracks, and after that there is dental sclerosis that commences. All right. Then there is the zone of demineralization that happens, bacterial invasion, and decomposition. So right, so this is again the same picture that we've already discussed previously. This is the pit and fissure enamel caries. Now we are stressing on this area. This is the area that we're trying to look at. So when we're looking at the dentinal caries aspect, this is the broad base here, and this is how deep it has actually affected. So if you look at this is dentinal sclerosis, right? Whereas this mild whitish area would be the zone of demineralization, and then this is the zone of bacterial invasion and decomposed dentine because of basically its close proximity to the pit and fissure caries lesion. This is when it's smooth surface. This is already the enamel here, which is destroyed. This is the changes in the dentine. What we're trying to focus on is this aspect where there's a broad base in the DEJ and the caries lesion, which is showing your apex towards the pulp. So this is what it is. So in clinically, when you go on to excavate this lesion, these lesions would be much larger than their appearance on the radiogram. That is because of the fact that on the radiograph, the areas that appear radiolucent minimal require at least 6% of mineral loss to be detected on radiograph. Okay, the ones that are appearing darkly radiolucent is because of 24% loss of mineral. Okay, the zones of dentinal caries according to Studevant are normal dentine, subtransparent dentine, transparent dentine, turbid dentine, and infected dentine. This is something you would have already covered in your second year in conservative dentistry under the operative dentistry aspect. So early dentinal changes, first of all, fatty degeneration of Tome's fiber precedes the early change. Dentinal sclerosis of transparent dentine is formed. Reaction of vital tubules and vital pulp is to seal off against further penetration of microorganisms. Okay, they appear transparent when a ground section is viewed by transmitted light, and they appear dark under reflected light. Again, something that you are familiar with your knowledge of oral histology. So this is again the same slide that we had discussed under enamel caries. Now our focus is on dentine. So you're seeing the destruction that has taken place in dentine, right? And also in the pulp chamber, the reparative dentine that has actually been formed around over here. You can actually even appreciate the slight increase in opaqueness in the pulp chamber, right? So if you clinically excavate this lesion, that means you use your aerator and remove this amalgam restoration, you're actually going to find a big, huge lesion underneath it as compared to the clinical appearance of the lesion. Okay, so dead tracks in dentine caries, you know what dead tracks are. Dead tracks are basically empty spaces where odontoblastic processes are no longer there, right? So if we look at this smooth surface lesion, this is the lesion reaching the DEJ. So as soon as it's even before it reaches the DEJ, the first thing that happens is the odontoblastic processes, they retract, they form the dead track, and as soon as they retract from the advancing front of the enamel caries, they try to form sclerotic dentine to try and stop the microorganisms as well as the products of caries from further advancing and destroying the dentine. Now this change in dentine is because dentine, as I mentioned previously, is a living part, right? Whereas enamel is not is a non-living structure of the tooth. Okay, so dentinal caries is slower in older adults because of the generalized dentinal sclerosis as part of aging, which you know. The bacteria that enter the dentinal tubules and initiate caries are called pioneer bacteria. Okay, acidogenic forms are prominent in early caries, which initiate the caries in dentine, whereas the proteolytic organisms are predominant in deeper caries. And this is a photograph of a carious tooth, an extracted carious tooth, the ground section of that tooth visualized under polarizing microscopy. So courtesy, I've taken this picture from sciencefotolibrary.com. So this is the pit and fissure. This is the carious lesion. The black color is basically the carious lesion that we're seeing. This is the body of the lesion, right? This is the dentinal lesion that we're seeing, whereas all the other different colors that you're actually seeing indicate actually normal dentine around. The yellowish color that you're seeing is described as positive birefringence. That means there is demineralization that is taking place, slowly taking place, whereas here there is advanced loss of mineral giving rise to the larger destruction and cavitation. So advanced dentinal changes, what exactly happens? There is thickening and swelling of the sheath of Newman at irregular intervals along the course. Okay, there is increase in diameter of the tubules due to packing by the microorganisms or the microbes. Alright, the lumen becomes distended appearance is described as beading, varicosities, moth-eaten or rosary pattern, and this leads to something described as Miller's liquefaction foci. So basically, as caries advances through the dentine, we have microorganisms that get into the dentinal tubules, and as they go into the dentinal tubules, they are identified with basically the increase in diameter of the dentinal tubules because of packing, and the products of the dentinal of the microorganisms, the leaching out of the organic acids causes demineralization and thus causing liquefaction degeneration of the dentine, right? Now, this liquefaction is formed by focal coalescence and breakdown of. This is decalcified section of a carious tooth. So this is enamel space, okay, which is lost because of the process of decalcification. This is the entire dentine. What you're seeing here, the basophilic structures that you're seeing here are all caries. So these thin vertical lines that you're seeing are dentinal tubules with carious microorganisms in them. These are Miller's liquefaction foci of degeneration of the dentine, right? So as each tubule destructs, it coalesces and forms larger lesions, right? And many times these lesions actually spread laterally as well to form something called as transverse clefts. So these clefts that you are seeing, which are horizontal or rather are horizontally placed, destruction in the dental tubules. This is because of the lateral spread of caries through the dental tubules. It could also be because of the incremental lines, the spread of caries through via the incremental lines. Again, because incremental lines some are many times. So this is advanced dental caries. This is ground section view. This is microorganisms. This is what was described as the beading, the packing inside dental tubules. So as they get packed over there, they coalesce to destroy, and this is what happens. How dental caries. Right. So in areas of globular dentin, decalcification and confluence of the tubules occur rapidly because the globular dentin is a hypermineralized structure of dentin. Transverse clefts, as I explained, are present at right angles to the dental tubules and appear to occur due to the extension of the carious process along the lateral branches. This is now a picture of decalcified section of dentinal carious tooth, and what you're seeing here are two large transverse clefts that are clearly visible on the slide. All right, so these are the transverse clefts. Now, the importance of these transverse clefts clinically is that when you are actually excavating caries using a spoon excavator, when you engage in this region, you will notice that there is a certain glide of your instrument, and that is because of the presence of these transverse clefts. So when you reach from the infected dentine from the affected dentine to the infected dentine component, where it is already sclerosed but still appears brownish in color, you actually clinically end up let that dentine remain, and then you actually go ahead and do your restorative procedure. So in concept, it is believed that the infected dentine, whichever, if there are microorganisms left behind, if the restoration is done well and the seal is well, those microorganisms do not have the potency to initiate caries. Okay, so let's look at the last part, which was mentioned in the outline in my first lecture, that is the immunological aspect of dental caries. So we all know we've understood the concept of dental caries. We do know that caries is in humans is associated with the development. I mean, is there since the time humans are on this planet, and the most common organism that's actually causing dental caries is Streptococcus mutans. So we are also familiar that if there is a microorganism that is present in humans, it does initiate some amount of immune reaction, right? So S mutants has been identified to be weakly antigenic. That is, the immune response to the presence of Streptococcus mutant in as part of the flora in the oral cavity is very weak, and that is the reason that despite it being widely predominant in the flora, um, the serum and salivary antibodies providing active immunity against this bacteria have very little effect on the bacteria. But in the concept of immunology, there is active immunity and there is something called as passive immunity, which you're aware, right? So currently, you're also aware that vaccines are being spoken or are discussed in more detail because of the current pandemic, right? So I would like to mention here that caries vaccine has also been under investigation for the last 40 years, and many in vitro and in vivo studies and some human clinical trials have been conducted, okay, with the aim of trying to develop vaccines for caries. But uh, so far, we haven't yet reached that point where there could be a commercially viable vaccine today. Okay, so in a nutshell, dental caries is an irreversible multifactorial opportunistic infection. Treatment is costly, making it a public health problem. Okay, despite many years of promising laboratory research, animal studies, and clinical trial, there is no commercially available vaccine as of today. And this information is from your textbook, as well as I have referred to this article, which is one of the latest on dental caries. If you are more interested, you can always go ahead and read more information with respect to this. Okay, so this brings us to the end of this topic on dental caries. So thank you very much and have a nice day.